Our first presenter for today is Thomas Concannon, who is a senior policy researcher at the RAND Corporation. He is also an assistant professor of medicine at Tufts University School of Medicine and associate director of comparative effectiveness research programs at Tufts Clinical Translational Science Institute. His presentation, How Do You Know Stakeholders Have an Impact on Research?, will offer practical guidance for designing a multi-stakeholder engagement approach for a given project or study. If you have any questions during the presentation, please ask them in the chat box. And after the presentation, Donna Matrani will lead the interactive discussion with reactors and conference participants. So with all that, Thomas, are you ready to begin?
Yes, I am.
Great. Thank you very much.
Okay. Thanks for that hand up and thanks for the introduction. I would like to start off the presentation today with just a little more background on me and why this material matters to me. Prior to my career in research, I spent about 10 years as a patient advocate working with people living with HIV and AIDS at a time when medicines were not great and folks were facing the end of life. And much of what I'm presenting here today rose out of knowledge and experience I had during that part of my career. And what I have been doing for the past 10 years is my best attempt in partnership with stakeholders and other researchers to translate those experiences in the research world into practical guidance that researchers can now use to engage with and involve stakeholders in their work. My talk today starts off with two motivations. One, a positive motivation from 1987. It's a case study of engagement by patients in research and healthcare, followed by a negative motivation, a sort of cautionary tale about what not to do from 2009, what not to do when considering engagement activities. I want to then follow up with some of the work I and my colleagues, including both researchers and stakeholders, have developed around how to plan engagement. And then I want to conclude with developing work that I, again, am working on with colleagues, both researchers and stakeholders, on measuring if how we will know if engagement works. So motivation number one from 1987. This is a picture of a young man being arrested. He's actually being arrested after having chained himself to the balcony of the New York Stock Exchange. After the arrest, he said, "This is only round one. Lower the price or we'll escalate." When I'm giving this talk to a room full of students, I often ask who this person might be and what he was protesting. And I'll invite folks to make comments in the chat window as I speak. And feel free to call that out if you think you know what this is about. But I will move on to tell you the answer right now. This is Peter Staley in 1989 being arrested for a demonstration protesting the price of AZT, the first antiretroviral drug that was released to market for people living with HIV in that same year. It was released at a price of $10,000 per year, which nowadays seems quite low relative to other expensive medications. But at that time was, if not the most expensive, quite an expensive intervention. People living with HIV and AIDS were concerned that they would not be able to afford this potentially life-saving medication. So they formed demonstrations. At this particular demonstration, they had chained themselves successfully to the New York Stock Exchange balcony, disrupted the opening bell, and 4 days after the demonstration, they, quote, buckled and lowered the price by 20%, they being Burroughs Wellcome, the manufacturer at the time of this medication. From then on, the industry said it's probably smarter to try to talk to activists and placate them as much as we can. This is a quote by Peter Staley speaking many years later about his experience of that demonstration. 6 months after that demonstration, the FDA further reduced the standard dose of this medication by half, and therefore bringing the cost of the drug into a much more affordable range. So back to 1987, when ACT UP actually had formed. ACT UP emerged in that year near the end of the first decade of the pandemic of HIV and AIDS, in which people living with HIV had faced devastating illnesses, really a high risk of mortality at 31 deaths in 1981 and a cumulative 18,000, nearly 500 deaths by 1990. They recognized the inaction of most policymakers. It was widely known that the presidents of the United States had not uttered the word HIV in public until that year. They also faced a perceived grindingly slow pace of research in a time when care was urgently needed. So ACT UP formed to, quote unquote, take direct action to end the AIDS crisis. This is, imagine now 30 years later, this is a really profound change in the relationship of patients to the healthcare system. This was a group of patients who did not have a model of other activists to follow that would help them form their strategy. So they went everywhere. No corner of healthcare was off limits. Members of ACT UP engaged with healthcare decision makers, sometimes as antagonists and sometimes as partners in government, industry, insurance, and employment. And they trained themselves. They became self-taught experts in drug development and markets, in virology, immunology, and biostatistics, and in regulatory affairs. Through the work that they took on, they achieved dramatic change. I described the demonstration against Burroughs Wellcome and the profiteering from AIDS-related drugs. They worked with NIH and FDA to accelerate drug development. They also worked with NIH and FDA to establish alternatives to strict placebo control in randomized control trials. They helped form community research initiatives, which essentially took research out of academic medical centers and enabled enrollment into trials in community-based organizations. And this was a joint effort of stakeholders and NIH and AHCPR, now known as ARC. They worked on healthcare delivery, working with Health and Human Services leadership on the implementation of the Ryan White Care Act, which became a multi-billion-dollar program to support people living with HIV. And they worked finally with the CDC and NIH on creating an updated definition of AIDS in 1993, making the condition more consonant in the experience of women and people living injection drug users. HIV treatment today is now known as one of the great home runs for drug therapy. And really, ACT UP became a part of the success story that culminated in this discovery, in the development and then the rapid uptake of this effective treatment for millions of people in the United States and across the globe. The real upshot here is that ACT UP became part, not the cause, not the only actors, but part of the success story. And that activism by people living with HIV and AIDS really encouraged waves of new patient-initiated engagement in healthcare and research. But it's interesting. I made the transition into research around 2001. Finished my PhD in 2006, and as I did that, I began to understand that that research, academic research in particular, was mostly shielded from patient activism. But that was changing at the time. At the time, there was new funding for this thing called comparative effectiveness research, a style or an approach to research, funded by the American Recovery and Reinvestment Act and the Affordable Care Act, which introduced new requirements for patient and other stakeholder engagement, and then ultimately the foundation of an organization called the Patient-Centered Outcomes Research Institute, or PCORI, which developed detailed guidance on engagement of non-researchers in the work of research. And then PCORI guidance since 2009 has influenced funding from AHRQ, the Agency for Healthcare Research and Quality, from the National Institutes of Health, and from other health and human service agencies. So as this transition happened, I heard from a colleague, a researcher, who said, geez, I don't know if this is worth it. This is hard, trying to involve patients in the work of research. You need training. It's hard to do. And I don't know if my effort here will be worth it. And it made me think of an experience I had as a patient advocate. When talking with other patient advocates, I heard someone say, this job would be great if there were no patients. Well, it was meant as a joke, in part because, it was a patient bringing personal concerns time after time after time about the way programs were run and delivered, made jobs just that much harder. And so what I did at that time, when I heard this from a researcher many years later, I began to think, well, why not take the experience I had of learning about how to engage with patients back as an advocate and translate this to researchers? So I partnered with, at the time, about 25 stakeholders and other researchers to begin writing guidance to other researchers. And now has grown to a consortium called multi-stakeholder engagement, or MUSE. It involves researchers and stakeholders from the United States, from Canada, Australia, and the UK, and has nearly 100 members. And we ask ourselves, if researchers engage patients and other stakeholders, will there be more success stories like those of ACT UP? So on to the next motivation. This is a person speaking on Larry King Live, CNN, who was talking about a failure in recent research in 2009, in which she said, feedback about the recommendations made by this research makes it clear that we need to have better messages. And knowing this is 2009, I'd ask if you want to weigh in the chat window, what you think this might be about. This is Diana Petiti speaking with Larry King. She was the vice chair of the United States Preventative Services Task Force, speaking on the widespread opposition that had emerged to a recent release of new guidelines for mammography screening, published by the federal government. A little background. USPSTF, the United States Preventative Services Task Force, includes some experts and engages with some stakeholders. There are 16 volunteer members who are experts in prevention, evidence-based medicine, and primary care. They engage with partner organizations outside of the task force, such as medical societies, insurers, and consumer organizations in activities before their work gets underway, doing guideline development. They engage with these folks to do topic identification and nomination, and then prioritization of the topics that come forward. And then once guidelines are completed, they work with these external partners on dissemination of the new guidelines. But the task force does not engage with all stakeholders during guideline development. They exclude stakeholders who do not have methodological expertise, and that principally includes patients. They also exclude certain stakeholders if they have a perceived conflict of interest. And this includes stakeholders like the for-profit stakeholders in industry, insurance, employers, and some subspecialties of medicine. Little background on the guideline that was released. It was a reissue. There had been existing guidelines, and this review found that mammography screening was successful at reducing breast cancer mortality on average by 15% in women ages 39 to 49, 14% in women ages 50 to 59, and 32% in women ages 60 to 69. But they found that the younger group, 39 to 49, was more likely to have false positive diagnoses from mammography screening than the other two groups. Their recommendations were for routine, biennial, that means every other year, screening for women ages 50 to 74. I'll scroll back to the last screen. 50 to 74 is roughly the last two groups in their study. They said that mammography for women younger than 50 was recommended only after considering individual factors and patient preferences, but that it should be available. It just should not be routine. Women of all ages, any age, should talk with their doctors about their risk for breast cancer. And this is really important. The guidelines said women should talk to their doctors about their preferences for screening. This screening should be available. And if women have strong preferences for screening, by all means, they should get it. This part of the guideline was really seen as contentious. Mammography for women was the most contentious part of the guideline. Mammography for women was recommended for women only younger than 50 only after considering individual factors and patient preferences. You would have thought from the response after the release of this guideline that this was the only part of the guideline. And that's what Diana Petiti was saying, that they had not messaged the full set of recommendations well enough. The release of this guideline unleashed vehement opposition from radiologists, oncologists, patients, and advocacy groups. And I would ask, if you want to weigh in on the chat window again, who are these individuals in the context of what I've just been talking about? These are the groups that were excluded from guideline development. They said that new guidelines would, quote, turn back the clock in the war on breast cancer. And they asked for and got bipartisan legislation that guaranteed coverage of annual screening, never mind that the guideline did not bar annual screening. And many physicians and institutions resisted these guidelines. In the end, the guidelines did not substantially alter screening practices. Really a terrible waste of federal resources to pursue that study and to issue the guidelines in the way they did. My message is that this wasn't a problem of just messaging, that this was a problem of exclusion of stakeholders, that in this case, exclusions backfired on the developers of these guidelines. I and the consortium I work with recommend that that researchers use a structured process to identify and recruit all stakeholders. What is a stakeholder? A stakeholder is a person who uses, a stakeholder of research is a person who uses research evidence to make decisions or is affected by the decisions that are made on the basis of research. And all stakeholders are experts in their own views, including patients. And that conflict of interest can be managed and is not an excuse to exclude industry and subspecialists. We also recommend that the researchers understand how we engage is an important factor. We really need to start by preparing everyone. All of the non-researchers who come to the table to work with us should get some preparation to understand the basics of what we're doing, the methods we use, how we plan to inform new decisions after the research is completed. That stakeholders ultimately need to meet each other at the same place in the same time. And the reason for this is that we need, as researchers, to see how stakeholders view a problem that we're trying to study, anticipate where areas of disagreement are and agreement. That it's important for us as researchers to create and sustain relationships with non-researchers. That sometimes meetings with between researchers and non-researchers should be led by experts. And that we should choose the modes and methods by which we interact. When I say non-researchers, by the way, I want to point out that almost no person fits cleanly into a researcher or non-researcher designation. It's just where the principal identification is. It's important to choose modes and methods of involvement very carefully. And get advice. Get advice from the many emerging experts on engagement. We also advise that engagement is just like any other activity in research. You can do it right. You can throw resources at it. You can spend time on it, and you can still fail. There is no guarantee of success in trial enrollments, in the methods you've chosen for study, nor in the approach you take for stakeholder engagement. It's just like any other activity. It does require trade-offs with other goals of research, and those trade-offs include personnel time and resources. So on to the nuts and bolts here, how to plan engagement activities. We recommend 4 considerations before you begin as a researcher engaging with stakeholders. Think first about why you're working with stakeholders. It's important to think about the intrinsic reasons. Intrinsic reasons are the reasons you would choose just because it's the right thing to do. In other words, we recognize that patients and policymakers and insurers are usually actually people who have dignity, autonomy, and have an interest in the way our share of the federal budget is spent. It is just intrinsically the right thing to do to be accountable to those people. We also recommend that you think through in answering this question, how would engagement potentially improve your research? How can these individuals help you do a better job? And then ultimately, how can engagement improve healthcare or health outcomes, which is ultimately the goal of all of our activities here. We suggest that you ask yourselves as a researcher, with whom will I partner? I talked about models for identifying stakeholders. I'm going to show you a few models, and we recommend that you choose a model to systematically identify the individuals who have a stake in the work that you do. Be asked to think about what the research is for, what decisions is this research meant to inform, which communities make those decisions, and which communities are affected by those decisions. And then we recommend that you through and talk to these communities about how they wish to be engaged. Don't assume that you know. So these are 3 frameworks. I apologize for the small font on this screen, but I want to point out that you can look at this handout in the handout that was Stephen Boydston pointed you to at the beginning of the presentation. What I want to say about this is that this presents 3 models for identifying stakeholders. On the leftmost column of this table is a listing of 7 Ps. These are patients and the public, providers, payers, purchasers, policymakers, product makers, and principal investigators. Across the rows, you see 2 additional, and I should say these are 7 Ps and a definition of the P. And then across the 3 major rows, you see 2 additional frameworks for identifying exactly the same groups. The PCORI model and something called the Centers for Medical Technology Policy Model. CMTV model. And the point of showing this is that these three frameworks developed at about the same time, independently of each other, identified the same communities. This is important. If researchers in looking at our work across several organizations identify the same communities, what I can say is that if we scan appropriately across our environment through each of these groupings, it is unlikely that we will fail to find a person with a stake in the work that we do. So it's important to start with a framework for identifying stakeholders. This again, small font, apologies. The 7 Ps are arranged on the leftmost column of this table, and this is a worksheet for researchers. We recommend that researchers not start by identifying the names of patients and the names of providers, but rather, what decisions do patients make that we seek to inform by the research we do? What decisions do providers, health systems, clinicians, nurses, other providers make that we seek to inform? And then to ask, how are these communities affected by those decisions? And together, these two middle columns represent the rationale or the reasons these folks should be involved in the work. We then recommend that you move to the next rightmost column and identify a target number for each group. And this allows you to think through what the appropriate balance will be among these communities. Do we want to overweight patient groups and make sure that patient voices are heard strongly in the engagement work that we do? And then once your target number for each community is identified, that you then begin identifying the names of individuals who can fill those roles. And the reason for this is this will help us as researchers come up with reasons and a plan before we start thinking through the who will do the work and who will contact. The third consideration we recommend before you begin is to think through how extensively will the stakeholders be engaged, and think about this in 3 phases of research: before research, during research, and after research, or in preparing for research, in conducting research, and in using the research, using being disseminating and implementing the findings. And then think through how intensively can stakeholders be involved in each of the activities in these 3 stages, and what resources and time will you devote to supporting those engagement activities. A fourth consideration: what are the appropriate roles and the modes by which stakeholders might be engaged in all of the activities you've identified before, during, and after research? About the roles: will stakeholders have control over the project? Will they help the research team carry out the research? Will they provide input but neither conduct nor help with the research directly? About modes: will activities be conducted in person or remotely, via the web, by telephone, in meetings, by email? Will activities be conducted with individuals or with groups? Will stakeholder communities, the 7 Ps, be mixed in multi-stakeholder activities? And what conflict of interest procedures can we implement now, and conflict management resources can we implement now that will be needed to manage the discussion? And this, again, is practical guidance. This is just arraying in the before, during, and after research stages, preparing for research, conducting research, and using research, 20 research activities, and then arraying the 7 Ps across columns, and enabling researchers to think through what is going to happen in each one of these cells. Not that something needs to happen in every single one of these cells. Sometimes these cells might be blended together, and activities will be blended across stakeholder communities. Sometimes the cells might be left blank because there aren't enough resources to actually carry out that activity. As you can see, if researchers went about filling every single cell, it could become a daunting, expensive, and frankly, not efficient approach. So this is really a way to get a handle over the entire range of your activity as you carry out research, plan for and carry out research, and plan accordingly. So if you've done both of those things, you've identified stakeholders systematically, and then you've done a careful job of planning the activities of engagement, how will you know if engagement works? Well, this is developing work, and again, I'm working with the Muse Consortium. This is nearly 100 individuals. Not all would become authors, co-authors of this, but all have the possibility of participating in this work in one way or another. And I would invite audience members to contact me after this presentation if you have interest in participating in Muse. We've begun to think about 3 dimensions of impact. Number one, we need to have really good inventories of engaged research. How much is happening out there? In the United States, we spend about $35 billion annually on doing research activities at NIH and in other HHS agencies. So how much of that $35 billion is engaged with outside communities, with stakeholder communities? I would say probably currently not terribly lot. But then by condition or patient group, how much of the work that's being done in research is involving those patient groups? We need really good inventories. We need to know better what we're doing, how we're doing it. We also need to assess whether the work of engagement involving outside groups adheres to principles that we've set forth in recent work for patient-centeredness, for engagement, the material I'm talking about today, and for something called translation, or how research moves on in a life cycle of evidence and is used by others. And then finally, and this is really the target, this is really why we're all here, we ought to think about how stakeholder engagement itself, not research, but stakeholder engagement itself, has an impact on healthcare and on health outcomes. Does it? Does it have an impact? If it doesn't, that will tell us quite a lot about how much time, effort, and resources we ought to be spending, and whether we ought to change our course of action, whether we ought to alter the way we do engagement activities. Again, small font. This is the chart I showed you earlier. This chart can also be helpful in creating a research plan that could be written into study registrations. Many of you may be familiar with the NIH reporter system, which is a registry of all randomized controlled trials funded by the NIH, or with Prospero, a registry of systematic reviews of research. These registries are meant to lay out the plan for research before it's carried out. We recommend that the material developed by through working on this form and summarized in very brief paragraph, perhaps, be included in study registration so that in the future we can do better inventories of the kinds of engagement that is happening out there. And this diagram is our just startup working model for what we're thinking about measuring the impact of engagement. And I'm going to try to walk through carefully. There's a lot here. In green, the leftmost box and the topmost box of this diagram are the leftmost box, the stakeholder type, the 7 Ps I described before: patients and the public, providers, purchasers, payers, product makers, policymakers, and principal investigators, who move into the circle in the middle of the red circle in the middle of the diagram as partners. In the top box are the modes and the methods by which they are engaged in that work: before research, during research, and after research. In the red oval, the set of activities of research in red and written around the borders of the oval are 5 words. These are what we think are the key intrinsic reasons for engaging with stakeholders. By doing this, we might improve trust between researchers and the public. We might show respect for persons. We recognize the autonomy of decision makers, that relationships are important between researchers and these communities, and ultimately that justice is served by the use of public dollars, that we're actually doing the work that we do transparently and openly. And then I want to point to the 3 boxes at the bottom of this diagram. These are also in red, and they read the relevance of research questions, which really corresponds to the very earliest stages of research before you get started. You define research questions. How relevant are they to stakeholder communities? The middle box says transparency of research activities. So research activities, carrying out research. How well do stakeholder communities, folks not trained in research methods, folks who have a conflict of interest, how well do they understand the activities? How well can they articulate what happened during the research? And then in the rightmost and lowermost box, adoption of research findings. This is our goal. When we involve stakeholders, we would like to see them use the work that we produce, the evidence that we produce. We would like to see them use it in decision making. This is what we this is work of research around dissemination of the findings of research, and so we want to see that translate into adoption, into actual decision making. And so these red ovals, the red oval and these 3 red boxes, you can see they're all connected by arrows. And the research activities in the center of the oval are connected by arrows. If we do this well, the theory is, we don't know, but the theory is that these activities could point to better health care, and lower costs. We ought to be testing this. This is a matter of evaluation and further research, but this is the hypothesis on which we've embarked. And we think that this is a potential model by which we might plan out an evaluation activity. Aside from writing an inventory and adhering to principles, the procedures of stakeholder involvement described on the previous 2 slides, we ought to ask stakeholders a series of questions about the impact of engagement. And specifically, we should ask, is the research question that was just undertaken relevant to decisions you make? If not, were you involved? Were your community members involved? Were other communities involved and community members? We should be asking, can you describe what the research was about? If communities can't describe what the research was even about, how are they going to use the research in decision making? How will they defend the research against other communities that trash it? And that does happen in public debate. And then ultimately, we should be asking stakeholders, how will evidence be used in your decisions? And these are questions that we can ask in routine surveys about the research work we do. They clearly need more wordsmithing and more development. These might be parent questions with a series of sub-parent questions underneath. But we ought to be moving in this direction. And that's the end of my presentation. Thank you very much. Back to Stephen Boydston.
Thank you very much, Thomas. We very much appreciate it. So now we're going to go over to Donna Matrani, who will lead the interactive discussion. Donna?
Thank you, Stephen, and thank you, Thomas, for a great presentation today. Before I introduce our reactors for the day, I wanted to remind everyone and encourage you, should you have any questions or comments that you'd like Thomas or any of our reactors to address during this discussion today, please feel free to utilize the chat pod to the left of your screen, and we'll make sure to get these answered as best as possible. And with that, I'd like to introduce our 3 reactors for the day. First up is Jennifer Weaver, a research associate for the Department of Clinical Research and Leadership and a doctoral student in translational health sciences at the George Washington University. Dr. Eileen Brennan, research professor of social work and investigator at the Research and Training Center for Pathways to Positive Futures at Portland State University. And Lorraine Johnson, the Chief Executive Officer of LymeDisease.org. She currently serves on the steering committee of Consumers United for Evidence-Based Healthcare, the Society to Improve Diagnosis in Medicine, and has been extensively involved with PCORI and PCORI-NET as a patient representative. So thank you to our three reactors for participating today. Before we turn over to our reactors with some questions that we had developed for them ahead of time, I do want to address some of the questions that have come up from our participants today. And so Thomas, our first question for you is, does stakeholder engagement equate to integrated knowledge translation? And as a reminder to folks in the conference who might not be as familiar with the term integrated knowledge translation, this is referring to the process of integrating knowledge translation at the front end of a project as opposed to waiting for the end of the project to incorporate knowledge translation strategies.
My response to that would be that certainly that strategy is exactly the same strategy that that we recommend. That it's really very, very important to integrate the voices of stakeholder communities, even as we are nominating topics for research and then forming research questions and then planning research protocols. But I wouldn't say it equates exactly because engagement may, in fact, involve other activities that are tangential to or maybe not pointing directly to knowledge translation. I'm just going to caveat that by saying that I would have to think more about the word equate, but I think they are clearly closely related.
Thank you, Thomas. Our next question comes from Laura Cohen, and she says, excellent comments, Thomas, on impact on healthcare access and policy. Interested in your recommendations about the following. There are many barriers to getting new innovative products to market due to coding, coverage, and payment barriers. Thomas, how do you suggest that research agencies align and collaborate with our policymakers and payers to help them amass the evidence they need, but at the same time ensure there is a balanced and achievable standard to develop evidence and timely transfer of knowledge to practice and implementation to intervention? This is especially true for small heterogeneous samples where randomized controlled trials are not appropriate. The more N=1 approach is more robust.
Wow, that's a lot.
And yes, Thomas, it is a lot. So if it would be helpful, Laura's comment and question can be seen in the chat pod on the left if it would be helpful to read it as well.
Okay, and could you just reread the very beginning, which I think contained the core of the question?
Sure. There are many barriers to getting new innovative products to market due to coding, coverage, and payment barriers. How do you suggest that research agencies align and collaborate with our policymakers and payers to help them amass the evidence they need, but at the same time ensure there is a balanced and achievable standard to develop evidence and timely transfer of knowledge to practice and implementation to intervention?
Okay, so how should funding agencies, research funding agencies, partner with policymakers? I mean, I think it's absolutely critical if research funding agencies wish to see the products of our research, publications, do more than collect dust on bookshelves, that we ought to see it moving from from our laboratories and from our institutes into the policy field, into the development of payment policy, into the acceleration of drug development, the implementation planning for a new intervention. If that's the goal of funding agencies, and I would venture to guess that for all $35 billion in the United States spent in this way, that it is in fact the goal. And so I think funding agencies need to really seriously bring policymakers into the process of nominating topics for research, at least being present and witnessing the prioritization of research within institutes and centers of the NIH and within the other research funding agencies in HHS. That would be a really good start, is involvement in the process of nomination, prioritization in some way or another.
Thank you, Thomas. And so now I'm going to move us into a discussion with our reactors today. And this first question is for Eileen Brennan. As Thomas mentioned many times, stakeholders are experts on their own views. Consider a situation where a stakeholder's views may be inflexible or perhaps in direct contrast to what research has shown. What would be the most effective way to work collaboratively with that person or group of people?
That is a great question, and exactly why I love this material. It really brings me back to the beginnings of the Ryan White Care Act when I was managing a small community clinic, and we were suddenly presented with the need to involve 25% to seat our board of directors with 25% comprised of really a brand new requirement, and really took the board of directors by surprise. But this was a contingency of the funding we took. In doing that, we do bring individuals on with rigid opinions. Sometimes those opinions are not well informed by past evidence. And so a couple of things. No person is the sole representative of their community. It's super important that we not put patients in that spot, that we not make patients out to be the token representative. We need to support patients by bringing in a diversity of voices. And just a second, I had a call coming in that just interrupted my line of thinking. So, and then secondly, we need to stick to it. We need to persist and sustain relationships over time. I want to bring attention to a current controversy in stakeholder engagement, the anti-vax movement. This is really challenging for many research communities, many research experts to really think about what went wrong there. But that represented, right or wrong, it represented a movement by members of the public to challenge evidence that was being produced by the research community. That is the gist of this challenge. And I would venture to say that all evolved in the wrong way because these communities were not meeting at the same place in the same time. And over 10 years, a parallel track of opponents of vaccines and proponents of vaccines was developing that ultimately collided, and now is like an epicenter in LA where some of these preventable conditions are coming back. The problem here is that we need long-term sustained engagement where we persist as stakeholders with these relationships, that we tolerate disagreement, that we not take disagreement to be the sole voice representing a community, and that we expose individual voices to diverse views within their own community. Back to you.
Thank you, Thomas. Thank you, Thomas. And Eileen, curious if you have anything to add there in terms of what would be the most effective way to work collaboratively with that person or group of people. We're talking about stakeholders specifically.
Yes, absolutely. I'm part of the Research and Training Center on Pathways to Positive Futures, and we work to design and improve services to young people who are age 14 through 29 who are experiencing mental health challenges. And what our project involved was designing training for service providers, including peer support providers who are working with these young people, usually in the community. And we brought together training collaborative, and that involved service providers, program administrators, researchers from different disciplines, young people with systems experience who were part of a national organization called Youth Move with 60 affiliated chapters in 35 states, and also family members who were raising young people with mental health disorders and who had joined family support organizations. So there was a wide range of opinion there. And we had a program that we were working on to design graduate level training, and they were saying to us, you've got to have this at below graduate level training, that you really need to look at who is providing services and get training prepared for a much wider group. And the thing that was important there was we did do what Thomas suggested. We really did listen, and we learned to be flexible. And they basically kept moving us in different directions that we weren't expecting given the literature review that we had done. And that was really very exciting because they helped us to implement the training and helped us to evaluate the training. So we had this group of collaborators with us for an entire 4-year, 5-year period during which we designed, developed, implemented, and evaluated. So we certainly learned a lot from them. I'll say one more thing, and it has to do with the fact that we were planning to do a segment on culture, and they convinced us that we had to do much more because we were not preparing people to work with Hispanic or Latino families, African American families. A general thing on culture would not do. We also brought in specific content about Native American families and tested that later, and maybe I'll talk about the test later on. Thanks.
Thank you, Eileen. Our next question is for Lorraine Johnson. As we have seen, researchers have taken deliberate steps towards trying to include their stakeholders in research. As consumers and stakeholders within our communities or larger social networks, are there ways we should work to position ourselves to better work with researchers and their practitioners?
I think that's a great question. We at LymeDisease.org, we have launched a patient registry, so this is going back to one of the points that Thomas raised about the future of research, and we have 11,000 people who are registered in our registry for MyLyme data. And what we believe is we believe that patients need to be building research capacity of patients directly. And they need to be doing that and reaching out to researchers at the same time. So there was a question that was asked earlier, which was if the researchers engage more patients. And I would sort of flip that question on its head and say if the patients engage more researchers and have the capacity to do that, because that really starts to become a conversation changer. And then the last point that I would make is that I think that patients and patient activists need to become part of the rule makers. So I was fortunate enough to serve with PCORI and be on their patient engagement advisory panel, to serve on their executive steering committee with PCORNet. And in that role, I was able to influence the rules that were made. So when we look at, the grid that Thomas was showing with PCORI's engagement rules, I was actually involved in creating those. And that's the type of role that I think patients need to be stepping into and becoming empowered to take on. It's a new role.
Thank you, Lorraine. And Thomas, I'm curious if you have anything to add there from your perspective, how you feel consumers and stakeholders should position themselves better to work with researchers and practitioners. So sort of flipping it like Lorraine said.
Yeah, really, it's a great question. Consumers really with a high motivation to learn about research methods ought to maybe come to the research table as best prepared they can be, understanding in general terms, what kind of research is being conducted, and in general terms what the approaches are. And you know, in the first link that I've just shared in the discussion window is a model for that, the types of evidence that is being produced and how they might prepare, how you might prepare for engagement in that type of evidence.
Thank you. Our next question is for Jennifer Weaver. Many times, practitioners are well positioned to be an intermediary between researchers and consumers and stakeholders. What are some of the challenges you faced when working with researchers or finding relevant research for practical application?
Great question. Seeing as it's a little bit of a two-pronged question, I'm going to talk about the challenges I've faced when working with researchers. And I don't think this will come as a surprise to many of you, but I think at kind of the forefront of it is communication. And I really focus on the communication piece because when we create these research teams with multiple stakeholders, we all come with our own individual expertise, and so we don't always speak the same language. And to kind of overcome some of these challenges, in some of the work that I've done, we've used some of the principles from the team science literature to create common ground about the research project. So just like Thomas was talking about and having the patients know in general terms about the research methods and methodology, it can kind of lay that common ground for everybody to communicate in the same way. Another aspect that I think is really important when creating these teams with stakeholder engagement is to have that psychological safe space. And we see that more in the organizational literature. But I think this is really important because we want those new ideas to be contributed no matter who the person is and no matter what level of knowledge they have about the research process. As a practitioner, I've worked with patients with traumatic brain injury for many years. And so in terms of thinking about the challenges that I've faced when finding relevant research for practical application, anytime I'm reading a research article, I'm thinking about the implications it might have for practice and, of course, how it might be adopted into practice. However, oftentimes when I'm reading new knowledge about interventions or assessments for cognition and traumatic brain injury, we are challenged to adopt some of the evidence into practice because some of it comes from, say, randomized control trials, and then we're thinking about introducing that intervention in a more complex environment, being the healthcare system. And I think a few other challenges that exist when considering adoption into practice is thinking about if it can fit within the context of where I work, right? Is it feasible for the setting in which I work? So these are all some of the questions that I ask myself when I'm reading the literature and thinking about implementing some new knowledge. And I think that really goes back to what Thomas was talking about and even in the chat box about that integrated knowledge translation or stakeholder engagement. But identifying the end user and selecting those stakeholders to engage in the research process is really critical then for the later steps when we're trying to disseminate and implement these new interventions and new applications.
Thank you, Jennifer. And Thomas, Eileen, and Lorraine, curious if you have anything to add to this question.
Lorraine, I would just, I'm sorry, I would just add that when I think it's really important when you're dealing with patients to empower them to understand what their role is on whatever committee that they're sitting on. And a lot of times if patients are not empowered in terms of understanding their role and what it is that they should be doing there in terms of representation of patient interests, they may believe that they should be there to represent their personal viewpoints and their personal interests, when actually their role there is much greater. And the personal interests matter, but also the community, having a broader understanding of what the community interests are is really important to bring to the table. So I think that would be an important training step.
Thank you, Lorraine. And Thomas, I believe you had wanted to chime in as well.
Just to say, nothing to add.
Fair enough then. Okay, so we're coming to, sorry, go ahead.
This is Eileen. One of the things that's been really valuable for our project is having young people with mental health system experience teach us from their perspective what it is that we can do that's more effective in training. And that has involved helping young people who are not familiar with research to understand what kinds of things we're hoping to learn about their experience that we can translate to research. So doing some preparation has been really important before they've gotten involved in our research efforts.
Thank you. So we're coming toward the end of our discussion for Thomas's presentation, but before we move forward, I wanted to open it up to Thomas and to all three of our reactors with any closing thoughts before we move to the next presentation. And so Thomas, we'll start with you.
No closing thoughts. I would like to underscore that this work is really at the stage of hypothesis generation. We are really trying to figure out, as a group of researchers, what and in collaboration with stakeholders, what will work. Lots has to be done to find out if we are right, and I would really welcome individuals with a strong interest in this to contact me for involvement in MUSE, which again stands for multi-stakeholder engagement.
Thank you. And Eileen, Lorraine, and Jennifer, any closing thoughts?
This is Lorraine. I would just add that one of the things that we're trying to do here that I think is very interesting, and Thomas alluded to it earlier, he was talking about doing the right thing, doing things because they're the right thing to do. And that is that we're really talking about this messy intersection of democracy and science. And so navigating the path through that, I think, is inherently very difficult. I'm not sure that it's been tried before, and will always have its challenges.
Eileen and Jennifer, any closing thoughts on your end? Okay, well, thank you so much to our participants for the great questions, and to our reactors, Eileen, Lorraine, and Jennifer, for the great discussion, and to Thomas for a fantastic presentation. And with that, I will turn it back over to Stephen. Thank you.